Good afternoon, everyone. Thank you for joining us. This is our, I believe, third in our series of swing bed webinars. Lindsay with Stroudwater will be presenting more on our swing bed topics today. And so, Lindsay, with that said, we have a smaller group today, but I'll turn it over to you and I'll watch the chat for you.
That sounds great. Thanks, Laura. Well, thanks everyone for having me. And good afternoon. So today we're actually going to talk about sort of two different topics, a little bit of a shift, not really a shift, but this is really about developing what we call a clinical care delivery spectrum for your swing bed. And it's a clinical framework. And you may be familiar with something for your acute patients. You may have something that you have and you utilize in your organization, or you may not. And this might be a totally brand new topic for you, but one that everyone knows that or thinks that maybe we should do something about this. So more to come on that. We're going to talk about it. So let's get started and move forward. All right. So what is a clinical care delivery spectrum? So really this is the how we define what type of patients we keep at our hospital, whether that's admitting to acute, whether that's admitting to our swing bed program. I mean, it can be used for observation status. You know, it could be used for any type of kind of clinical kind of level of care that you want to kind of develop this framework around. And it's also looking at who are the folks that we cannot keep, who we are typically transferring out. And those are, you know, patients that we may not have a certain offer a certain set of services to support their care needs. They might be of an acuity level that we cannot support. And all of this in developing the cans and the cannots is really based on a few different factors. And we're going to go into more of those, but it's around staffing competencies, provider availability, ancillary services. And those really will dictate whether or not, you know, you can safely care for a certain population or a certain acuity level at your hospital. And it's wide ranging and it varies between facilities and organizations. So there is certainly no one size fits all model. But we have found out that hospitals do not really go through a formal process of really defining those types of patients. And again, it can be for different levels of care. It could be for, you can even, you know, apply this type of clinical framework to, you know, other aspects of the organization, but really, you know, focusing on inpatient is really where this tends to work and is seen more often. And there is, you know, sometimes we always fall back on, well, we use admission criteria, and that helps us define, you know, what level of care that we're going to be admitting the patient to, or placing a patient in what level of care. But this goes kind of beyond that. This is really defining who is our ideal patient for our organization. So why is this developing a care delivery spectrum important? Well, we certainly have, you know, in the healthcare landscape, there's the continuation of rural hospital closures. There's also, you know, declining inpatient admissions and volume. At the same time, there's this challenge around staffing and staff shortages, and to be able to even grow because staffing may be constraining your ability to grow. So there's, you know, certainly lots of things going on from a volume perspective out in the market. And so with a care delivery spectrum in this defined clinical framework for your admissions, it's establishing these improved kind of workflows that are going to create greater efficiencies within that admission process. It's a defined agreed upon framework that's going to really help to make, efficiencies within that admission process. There's going to be a decrease in the variability of clinical decision making. And so, you may have a hospital that tends to admit, maybe a higher level of acuity patient into your swing bed programs. But then, in 2 weeks, you have another hospitalist that is in your, doing your admissions and may not feel comfortable keeping some of those higher acuity swing bed patients. So there is that kind of decrease in that variability when there's agreed upon clinical framework that will help in some of that decision making. Increase in patient and staff satisfaction. We found that, having a defined kind of framework, that care delivery spectrum, has been very helpful in kind of creating, a streamlined approach, and is a staff satisfier because we have a plan. It's not just it's just the temperature of the day, or it's this day of the week we do this. There is a defined process and framework that we all are following. And then if we do have that defined framework, it tends to lead to, an improvement in our bottom line regarding our inpatient revenue. The goal is to really, use this, defining who our patients are and be able to build our volume based on that. And as I mentioned, this is just a snapshot of rural hospital closures, and it certainly does impact the ability related to access. And, we are, volume declines that we're seeing impacting some of those closures. And then there's also and I've shared this slide a couple of times, but the variability related to swing bed utilization, and it's across the country. And it ties back to, there's lots of opportunity out there as it relates to volume growth around swing bed services. So there's, folks are not, we target, a ADC of 4 for every 10,000 people in your primary service area. And, I think it's the yellow here on the screen are those hospitals that are below that kind of set target based on their primary service area. So, certainly not fully optimizing swing bed programs. So when we look at developing a clinical care delivery spectrum, we want to, if we are completely successful in implementing a clinical care delivery spectrum, what are some of the key metrics that we'll see as it relates to improvement? We talked a little bit about the admission process and the patient throughput. Really streamlining your process will lead to greater efficiencies across the organization. Those inefficiencies, when a framework or a process is implemented, we hope to kind of resolve and reduce some of those inefficiencies that may exist. Increased in admissions, again, with the targeting that ADC of 4, we hope to get to that point, depending on your patient population and service area. A reduced cost, or in an opportunity cost, if you will. And then when we talk about improved value, again, appropriate patient care services are delivered. Patient care services are provided in the most appropriate care setting. And then the facility is receiving services or payment for services rendered. And then we also see it from a revenue aspect. If we're able to, define our patient population, folks that we would admit to our hospital, what that looks like, the goal is really on improved admissions because we've developed this framework and we're more consistent in following that, which then would lead to improvement in our census, which then in turn, we're seeing an improvement in our contribution margin for our increase in our census. And this is just a snapshot on a financial analysis in which a critical access hospital grows their swing bed census and what the financial impact of that growth of, I think we increased them to about 3 days, an ADC of 3 and a financial impact or contribution margin of about 192,000. So there is a financial component and a revenue stream generated based on improved admissions. But of course, with any new process or a defined framework that we want to develop, there are certainly barriers. And lots of areas that we have run into is we've always done it this way. We've always accepted, these are the patients that we've always accepted in our swing bed, and this is how it's always going to be. But there hasn't been, a coming together of key stakeholders to really challenge that we've always done it mentality. So, are we really maximizing or are we leveraging our potential? Could we be expanding on those patients that we accept into our swing bed program? So we have to understand those barriers. We need to and then go through an exercise of identifying the barriers and seeing if there's opportunities to work through those barriers. We run into this often, and it's around those what if scenarios. So, well, what if we accept that higher need swing bed patient? What if they need to get sent back to acute? It's those what ifs that sometimes create barriers to kind of, accepting a patient versus not accepting a swing bed patient. Are we missing some opportunities for those admissions? And, we need to, key items to consider when we look at identifying some of those barriers is around our medical staff relationships, communication, equipment, staffing, and certainly clinical competencies. So what are some key steps to really starting to think about in creating your clinical care delivery spectrum? We're going to walk through a few of those, but I think what you'll find familiar is the team aspect. And we firmly believe that, you cannot just have one person develop a clinical care delivery spectrum. There needs to be, it's a multidisciplinary team that of key stakeholders here, from nursing to rehab, the business office, and certainly a provider, where their involvement is important in establishing what that framework looks like. So for, to help with identifying which types of swing bed patients can be cared for or would be accepted at your hospital, we certainly need to go through the exercise of evaluating competencies, whether that includes, reviewing any special licensures or certificates. Maybe you have a nurse that is certified in wound care. And so because of that, you have the ability to support additional admissions based on maybe wound care needs. Certainly staffing, and again, looking at whether it's you have ratios in place or what do your shifts look like in your mix. We're seeing a lot more inpatient staffing mix changed based on the staffing shortages, where a lot of hospitals are leveraging LPNs a lot more. So what does that look like? And that staffing complement look like to be able to support, a certain level of acuity within your swing bed population? And certainly clinical leadership structure, and the understanding around skilled care services and what skilled care, what constitute as skilled care, what does a patient need to meet or what does a patient have to meet the needs of skilled care? Again, making sure that that is consistent and we all have an understanding of those needs or services. And then providers, again, a role of a provider in this is really around having the opportunity to kind of look at what are the services offered, are there on-site availability, opportunities to expand access, what types of, ask the question to the providers and check the pulse on what types of patients did they believe are appropriate for swing bed admission? Did they have any concerns, whether it be with staffing competencies, clinical care competencies? And then if there's any additional staff education or training needs that they believe needs to happen as it relates to the swing bed population and supporting those needs. And of course, the involvement of rehab. So, understanding what rehab services are currently available. Are there variable hours? Sometimes we'll have, you only have a outpatient rehab group that supports your inpatient rehab needs and sees your inpatients on a very sporadic basis. Well, we need to understand kind of what those hours are, what's the availability of those services if we're going to be developing this clinical care delivery spectrum, and what services cannot be provided, where are there some gaps in rehab services. Maybe our rehab we don't have speech therapy. We just need to understand where some of those gaps are. And of course, supplies and equipment, an evaluation of what is available, because that will certainly dictate or have an impact on the types of patients that you admit into your swing bed program. So are we evaluating the age of the condition? Do we need to replace anything? Do we have wound vacs or bariatric equipment? Certain things that would either limit or expand the ability to care for a certain type of swing bed patient in our program. If equipment or supplies are not available, can we get them? What does that look like? And pharmacy. So again, the involvement of pharmacy, making sure that we have any type of medications that won't maybe not appropriate for swing bed. Do we have a robust formulary that we can, we have all the necessary drugs and medications available? And if we don't, can we get them? Is there a after hours pharmacy or any type of resources that we can get medications that would be able to support those swing bed admissions if that's not something that we have readily available in our hospital? And then last part of our interdisciplinary team is around the business office. So what types of insurance are we just looking at? Medicare Advantage? What's the process for insurance verification for each patient? Are there prior authorizations needed for that insurance coverage? Having all of this ahead of time helps define or makes the process for accepting and not accepting a patient smoother and more efficient. And then it also, lends itself to defining who that ideal patient is for our hospital. And so once we bring all those key stakeholders together, we talk about any of the barriers. We understand kind of from we inventory. It's almost like we do our own gap analysis of where there may be some barriers. What are some of our strengths? What are our weaknesses? Then we take it, another step, and we start to understand, okay, well, what's going on in our market? What is the patient population like? What does that look like for our skilled care patient population? What do we currently have for in-house utilization? What might the market be like from other SNFs in our market? Where is there competition? Because if we're going to be growing or expanding or accepting maybe a different type of patient, well, are they out in our market? Can we be able to do that? What is the service area population characteristics? Are we serving an older population? Do we have industries within our population? What does our market demand for skilled care needs look like? So we need to do a little kind of outside the walls of the hospital intel. And this is just a map of some area skilled nursing facilities for a critical access hospital and I'm going to use this example a little bit later, where they actually currently do not have a swing bed program. And they really wanted to utilize, what is that? If we wanted to start a swing bed program, what does that look like for us? And having this, developing and going through the process of developing a clinical care spectrum, we can help kind of show them what that may look like. And so again, understanding your patient population in your service area, this is, all the skilled nursing facilities around them. So their issue was that they were sending their skilled patients miles and miles away and outside of their community. And they were like, well, this is just the silliest thing ever. So we're, kind of working with them to bring that back in-house. And then the third thing is, okay, we work with our interdisciplinary team. First thing, we understand our market and the needs of our market. And then the third thing is, and I'm going to switch gears a little bit, and we're going to go to the swing bed directory portal, but is to really leverage the swing bed directory. And some of you all have filled out the swing bed directory, and you come up with this opportunity matrix, and it helps define if there's an opportunity based on your inputs related to your resources and your services provided, or if there's a conflict or a match. And so this will help to kind of start to create some questions and answers around the question around who do we keep and who do we not accept in our swing bed program? And what does our swing bed program look like from an overall service delivery programmatic standpoint? So I'm going to switch gears for just a second. And I'm going to use one of your peer hospitals as an example. if I can find the internet. Okay. So do I have anybody on here from Mercy Hospital Tishomingo? Sorry, did I not? Tishomingo?
Yes.
Who's on?
I see Shelly and I thought I saw Tia earlier.
Okay. Well, I'm going to pick on them for just a minute. It's nothing bad. Don't worry about it. Okay. So we are in the swing bed directory. So again, if you are not familiar with the swing bed directory, this is available to you all through the state office at no cost, but it's an opportunity to do a inventory of your clinical programs and your resources as it relates to your swing bed program. And again, to really understand if there's opportunities for growth and expansion of utilization. And so what we're going to do is we're going to look at their opportunity matrix. Okay. So this is the end result. And if you go here, you can see the list here of all of the clinical programs that the portal or the data kind of looks at. And you can see here under opportunity is around pulmonary rehab. And again, pulmonary rehab may not be directly tied to your swing bed program, but let's click on pulmonary rehab just to talk about it for just a second. So this hospital answered all these questions as it relates to pulmonary rehab and the resources related to pulmonary rehab. So, clinical competencies, we have different equipment, some, process of care type. We have see equipment here, what the facility is like. So all of these are checked yes. So doing a lot of the, what we consider supportive of a pulmonary rehab program. But if you go back to the, it's considered an opportunity because Mercy Hospital Tishomingo does not offer pulmonary rehab. Is that correct? Anyone on the phone?
We don't at this time.
Yeah, so this is certainly something that we would say, well, let's have a conversation. You have a whole lot of clinical competencies as it relates to pulmonary rehab. And you've indicated, no, you don't currently offer it. There may be a barrier, and it may have to do with, a specialty physician provider that you may need to help support that program. And that might be the case, but this is, something, okay, if we're going to, look to expand services, maybe this is one that we look at. We have a lot of the resources and the needs to support a pulmonary rehab program. So let's go back to the opportunity matrix for one more example. And this is, we're going to look at post-bariatric surgery rehab. So something that would definitely tie back to a potential swing bed program. And this was considered NA. So the hospital has indicated they do not have all the necessary resources. And they also they have said that they don't provide post-bariatric surgery rehab. And so it comes up as an NA here on this swing bed directory. So again, lots of clinical care competencies to be able to support that. We have different rehabs. But then when we get down to the two equipment needs around bariatric patient beds, the hospital doesn't have any. So does this then go to, well, is there an opportunity to, get 2 beds potentially. And then we can start to market and look at, is this an opportunity for us around bariatrics? And I'll have a side story in a minute about the use of, understanding maybe your patient population. Is there a high need, high obesity or bariatric population? Maybe this is something that we would consider. Now another question for the hospital. Have you accepted bariatric patients into your swing bed?
Not the one specifically for bariatric surgery, but it just depends on the exact size and the capabilities of the patient and what they can do for themselves.
Okay. Have you ever needed to get beds from somewhere else, like a lease of some sort?
Yeah, beds and, little bedside equipment for them, like the bedside commode or power chair, things like that.
Okay. But again, these are some of the, based on what goes into this analysis and how do we leverage and maybe kind of start to see it all pulled together based on the inputs. And these are some of the questions that we can start to ask ourselves or have a crazy consultant ask you. And then again, I would highlight the other, NA1 here is around short-term ventilation rehab. Similar to post-bariatric, didn't necessarily meet all 100% of the resources to support that clinical program, and also indicated no, that the hospital did not provide short-term vent rehab. So again, this one is around a clinical competency had been indicated no. So maybe is this an opportunity for some education here. And then again, it sounds like you don't have vents.
Just for our emergency room.
Okay. But again, lots of great things, lots of, a robust kind of clinical competencies here. So lots of good stuff. So potentially maybe some education or consideration of some specialty equipment, if that was something that you wanted to pursue. All right. Let me stop that one. Sorry, it's a little back and forth here. Okay. Oh, and I did that. So here I'm going to, this is the part where I get to do some storytelling. So as I had mentioned, that critical access hospital in Arizona, where they actually do not offer swing bed services. And the big key question for them is, is it feasible? The main concern for them is, we are sending folks out to skilled nursing facilities that are, 50 plus miles away from our hospital, but they're not going. We make the referral. They don't want to leave their community, and they don't want to go 50 miles away for an extended period of time from their families and their support. And so they just would not go. We're not going to any type of skilled nursing facility. So we wanted to understand, okay, of all of the Medicare patients that they were seeing, and they were sending out to these 3 different skilled nursing facilities, what were the primary diagnoses from the hospital? And so then if we can take those primary diagnoses of the hospital that they were going out for skilled care for, we can start to help the hospitals understand if this is something that they could, again, develop a clinical care spectrum around and define who's appropriate for their swing bed program or who is not appropriate for their swing bed program based on their clinical competencies, their availability of support, professional medical staff, so we can start to kind of shape what that looks like. So, their top diagnoses that were sent out were, after orthopedic related. We had diabetes, cellulitis, infections that might need long-term IV antibiotics, pneumonias. So all appropriate cases for this critical access hospital. So another exercise that we went through, similar to what you all did with the swing bed directory, was to do the self-assessment. And we looked at different, categories related to those resource requirements that the swing bed directory had in the different kind of resource subcategories that to kind of organize it all. And they had indicated that they did not have a nurse to be able to manage, PICC lines, inserting them or maintaining them. So if that was the case and that was a barrier to being able to provide, sufficient nutrition and infection management, then is there an opportunity to do some education and training for the nurses around inserting and maintaining PICC lines? So that was, certainly a recommendation there. Again, this is looking at an inventory of some of their equipment needs or their resources related to their facility. And they did have some kind of orthopedic equipment needs. And they also at the same time said, we have high rates of obesity in our community, but we don't have the special equipment to be able to support that patient population. And they actually say that they transfer any of their bariatric patients. So, is there an opportunity to really kind of reconsider if we have those patients that, don't want to leave their community, how do we support their needs and keeping them local? And then in addition to their self-assessment, they have certainly a wide range of meeting some of the education needs of the patient, but indicated that they needed more education and training in post-surgical, the use of stoplight tools, and the care of a patient with a history of substance abuse. So if we can, and this goes back to utilizing your nursing staff to do your, and to aid in helping in developing the clinical care delivery system is understanding where there's gaps in our education and our training. Because we want to be able to work to the top of our license, and we want to be able to meet the needs of our community within a safe environment. So if it's so it's really kind of bringing everybody up. Can we provide that extra training and education just to be able to support some of those needs and expand upon our potential patients that we keep versus patients that we don't keep in our swing bed program? And then this part of the self-assessment was around transitions of care. So there were some gaps, certainly in their transitions of care and their discharge follow-up phone calls that would, prevent any readmissions. And then their referral response time. They had indicated that if they were, they don't think that they could, because remember, they don't have a swing bed program, so they don't have referrals coming in for swing bed. But in their mind, they were saying, we don't have the ability to be able to, pull a team together and get a response back for referrals in under an hour. So again, if we want to, improve on some of those areas there. And then I just wanted to include kind of a snapshot here on, again, through that swing bed directory, you do have that marketing flyer. This is another opportunity to not only, after we've defined who our patient population is for our swing bed program, this is the opportunity to make sure that that is captured in some promotional and marketing material. So our referral sources know that. This is one way that we can do that. And through that swing bed directory, that marketing flyer can help you do that and help you kind of articulate that in a promotional way. So I know we've talked about swing bed and developing this clinical care delivery spectrum for your swing bed patient population, but this is very applicable to, as I mentioned before, to your acute patients, your observation patients, any type of kind of level of care patient that, and so I wanted to just continue to provide some examples for you all on how you can apply the clinical care delivery spectrum and kind of using the same process to look at different patient population types. So we worked with, I don't know, hopefully you can see this okay, but we worked with a group of hospitals in upstate New York, critical access hospitals, to do just that for their inpatient side. So who are the patients that we admit? Who are the patients that we transfer? And then there's always going to be this gray area in the middle. And so that's going to be the hardest part, is defining what that looks like. But we really worked with the hospitals to help them, start to craft these guidelines or these frameworks. And so this particular hospital just looked at cardiac cases and, looking at, okay, these are our, patients that come to the emergency department with these diagnoses. So depending on their level of acuity, in the column 1 here, column 2 is what we do with them. This is where they go. This is a transfer out, or this is maybe we put in observation, or this is an admission, or this is a discharge home. So depending on looking at some of these, clinical, how they presented, perhaps in the emergency department, and based on their diagnostics, et cetera, their results, this is what they've come up with here. And again, they just took, cardiology or cardiac cases as one example. So by doing this, though, they did actually have some interesting results in terms of their inpatient utilization. So they had an admission rate that kind of varied over the years, from an ED admission rate to either acute or observation at like 2.8 to a high of 5.3, very variable. And they'd always wanted to understand, like, why are we declining in sometimes and why are we increasing? So lots of variability. And so what they did was they looked at their ED transfers, and there were inconsistencies around how they transfer. There was no process related to how do we define who we admit. And so again, there we come back to the need to kind of help define that, and define that framework will and standardize a process will certainly help with your admissions. And so they implemented a clinical care delivery spectrum. There was certainly collaboration when they looked at just cardiology cases, between respiratory and cardiology and clinical leadership. And they actually saw a 10% decrease in their ED admission rate compared to the prior year. And they were being able to kind of keep some of those additional admissions based on this clinical framework. And then we have another hospital actually in New York, not from the same group, but they looked at, again, looking at their ED transfers. They had a high amount of ED transfers that were getting sent actually out of the state and actually getting sent to Pennsylvania. And they said, well, we have to keep more patients here. We can keep more patients here. We just have gotten into this, mentality that we've always transferred this type of patient. And we're just going to keep transferring this type of patient. But really, they could have kept, a higher level of acuity based on the competencies that they had. And so what they did was they looked at their transfers. They looked at 22 charts, and about 50% of those, 45% of those transfers were what we call potentially avoidable transfers. They could have potentially stayed at the hospital and been cared for and not transferred out and actually out of the state, and could have been a possible admission. And so what they, and so some of the, again, so there's that 45% decrease in ED transfers. They at the same time saw an improvement in their inpatient ADC, and they started to implement some initiatives and activities such as, we need a telehospitalist group. This will help keep more patients local and decrease some of those potentially avoidable transfers. They also expanded their echo tech coverage, and they did some equipment upgrades as well. So all to be able to kind of continue to support those increase in admissions based on really, taking a good look at their transfers, and then defining who we can keep and who we probably should transfer. And maybe even defining more of that gray area. So with that, I think that's the last slide. So any questions for me? Does anybody have any type of framework that they have, whether it's an acute kind of admission, not an admission criteria, but this is the type of patient that we keep here? Is this something that you all maybe think would be something that you do need? Do you find that there's inconsistencies with the types of patients, if you're looking maybe just at your swing bed program, that we certainly have some inconsistencies related to who we accept and who we don't accept into our swing bed program?
Heather from Hilton indicated yes in the chat.
Okay.
Lindsay,
Yeah.
I'm sorry. This is Laura. I know you mentioned the swing bed directory, and we did a big push to get people registered, signed on, probably a couple of years ago. This is an ongoing project, right? And we can add folks at any time, because I know there's some folks on the call today who might be new in their roles or weren't around for the first big push.
Yeah, absolutely. And yes, we have 10 hospitals that are active on the swing bed directory. And maybe your hospital has been using the directory. I'm just going to share my list right here. And maybe you're new and just didn't know. So if you want to have a conversation, we can certainly do that. So here are, and I don't know the hospitals that are on the line, but here are the hospitals here that are active within the swing bed directory, if that's helpful. So if you are new and want to chat more about the directory, I'm happy to chat more about it. Or if you're new and want to sign up, that'd be great too. Oh, I see Natalie. How do we? Yep. So send me an email. I'm going to put my email in the chat, and I'm going to put you in touch. We have like one piece of paperwork that you all have to sign just to get your info. Oh, I just put my Gmail. That you have to sign, and then we'll get you signed up for it. So that's that. And I'll put you in touch with Paula Knowlton. She's one of our analysts that supports the swing bed directory. So she'll help you get connected. And if you have more questions, I'm just happy to schedule some time. That's great. So we do have some new folks.
And I'll take down everyone's contact. Natalie, I'll send you a chat. Jessica, we've talked. Yeah, I think I'll take down everyone's name as well, and I can follow up too, Lindsay.
Okay. Yeah. Let me know what you need, and I'm happy to help. And if you have, and I always, certainly say this, if you have questions related to your swing bed program, or anything, we're here to help, and be a resource for you all. So I know that some folks have, contacted Laura with a question, and she's reached out to us. We are, a resource. So don't think that you need to reinvent the wheel. Someone out there has done something that may be able to answer your question, and then we can connect. And it's so anything related to operations, finance, you name it, we can help you. Okay. Well, good stuff, everyone. So thanks. I'm happy to hear some new folks are around the table. And I think we do have one more swing bed webinar this year scheduled. And we're going to talk, I think it's on care transitions and how that applies to your swing beds.
Yes, it's July 14th. I apologize. I had to look it up on my calendar. But yes, on July 14th. We recorded the webinar today, and as soon as we get it posted on YouTube, I'll send it out, and I'll also send out a reminder with the link to register for the July 14th webinar. So thank you, Lindsay.
And they'll send the slides too.
Perfect. And everyone have a great day. If you run into any questions or anything, please let me know. Thank you.
Thanks all.